So I'm going to talk about mental health today, just kind of share my experience. I've been working at my hospital for nearly 4 years as an enrolled nurse, and I've been studying at ECU for a year now, so I'll be a registered nurse next year. All right. It's going to be very informal, so if anyone wants to ask me anything or interrupt, please feel free just to put your hand up, a shout out, and I'll do my very best to help you, or Terry, I'm sure it'll help as well. Okay, so to start with, obviously I'm going to talk about the therapy role within mental health, interventions. I'll go through some diagnoses like depression, anxiety, diagnostic criteria and things that we look for in risk assessment. All right. So I've just put this in there, I was hoping to maybe just go through some stigmas as well on what people think mental health actually is and how it's defined in terms of health. So if I was to ask what is mental health, what would anyone say? Does anyone want to have a guess how they think mental health is defined? Anybody? No? It's all good. So look, I've put this in here. Has everybody heard of the World Health Organization? So this is kind of the guru for health, really, Terry, isn't it? Like research, head offices are in Switzerland, I think, aren't they?
Yes, but they're
all over the world. And if you go on in your careers and you've got to do more kind of academic writing and research, these are a great kind of resource to be referring to. There's a lot of latest best practice and things like that. So this is their definition of mental health. So a state of well-being in which every individual realises his or her own potential, can cope with normal life stresses, and can work productively and fruitfully, and is able to make a contribution to his or her community. So I found that interesting because for me, that's saying mental health is positive, and it's saying when we're all mentally well, and this is what it should be looking like when we're a well-rounded person. Not kind of initially diagnoses and negative things. So I've just put in how it should look when we're mentally well. So we should be like that first thing said, engaging in community, taking care of ourselves, showering, brushing our hair and our teeth, relationships, friendships, professional relationships, being productive at work. And this is an important one. We all have stress in life, which I'm sure now that you've all started studying, you can relate to, can't you? You've seen all these assignments and new things, families, you might be working. So this is an important part of life for all of us. But hopefully right now you're managing it and you're coping with it. But that's the difference with someone who's been mentally unwell. Able to contribute to your community, hopefully. Enjoying fitness and leisure, so getting out walking, being in nature. Good self-esteem, we'll talk about that maybe a little bit more when we talk about depression. And able to set goals, which again for you guys is relevant because you're all here now, you're all studying, so you've all got a goal to finish this course, get new jobs, so it's a great sign. So here's the difference in comparison. This is a quote as to how mental illness is defined. So a psychological and an emotional state which negatively impacts your mood, thoughts, behaviour and functioning. So that's anyone with a diagnosed mental illness will directly affect mood, functioning in life, work, ADLs, the thoughts that they have, behaviour, they might act very differently to people that they love or at work from what they did previously. So these are just things to keep in mind as to what we'd be monitoring if we end up working in that industry, but also kind of anywhere that we work as well, especially in residential aged care. Just some common diagnoses. So depression, major depression. So you might see this wrote in handovers as MDD. And then within that, there's different types. So there's postnatal depression, psychotic depression. There are a few more as well. Anxiety disorders, So generalized anxiety, social anxiety, agoraphobia, so this is where people would have a fear of leaving the house, separation anxiety. We'll talk about these a little bit more. Bipolar I'll go through a bit more as well. Psychosis we'll discuss. Personality disorder, I've put that in there. There are different definitions of that, kind of leave that for now. The reason that I've put post-traumatic stress disorder and obsessive compulsive disorder separately is they used to be under the anxiety umbrella, but in the latest DSM-5 they've changed to have their own kind of independent criteria for diagnosis and treatment. And then we've just put eating disorders in there as well.
Lee, do you want to explain what DSM-5 is?
Oh yeah, sorry, I've put that in later.
We haven't covered that yet in the class.
The DSM-5 is the Diagnostics and Statistics Manual of Mental Health, which is currently on its 5th edition, and that's what's used within mental health, so psychiatrists and doctors will use it for their diagnostic criteria. So each diagnosis will have set criteria that needs to be met for the person to get that diagnosis. I'll discuss it a bit more when I go through depression. I've put certain things that the doctor would need to kind of tick off and a person would be presenting with. Is everybody keeping up? Is everybody understanding me and stuff? Okay, so I've just put this in here because I wanted to highlight the importance of mental health. It's something that I'm quite passionate about. It's something within Australia that's growing, that healthcare workers are kind of getting more involved in. And for me, not just if you're working in mental health, but whether you work in a hospital, general, surgical, aged care, mental health affects everybody. Our patients, families, carers. So we'll go through this and just keep in mind how important it is for all of us, really. So this is from Beyond Blue, which is a really good website if anyone wants to look at it. But basically, this has been updated recently as well. It says that mental illness affects 1 in 5 Australians every year. So 20% of the population is a lot, I think. 1/4 of Australians will experience an anxiety disorder at some point of their lifetime. 1/4 of us. 1 in 6 Australians are living with depression and anxiety, or both. It's crippling. Females are more likely to experience depression and anxiety than males. However, males are 3 times more likely to die by suicide than females in Australia. It's interesting. And I think just keep in mind that maybe females would be more likely to help seek and see a GP or see a healthcare professional. So I think this is important for us to consider in our roles that we'll discuss, how we could have the effect to encourage someone to get help. So this is where stigma comes in, and we should be discussing mental health more. And if we think someone's struggling, just to kind of ask them and encourage them to get help. And there's lots of campaigns at the moment. What's the one that comes on the advert with the guy with the barbecue? I can't remember what it's called, but it's about getting people to talk and ask for help. So I think that's great. I've just put this one in about older adults as well, because I think that's relevant if you guys go to aged care for your placements. So it is quite high in older people, 10 to 15%, but significantly higher in residential aged care. So that number's doubling to 30%. So just keep that in mind. The positive thing is that people seeking support has increased, and now it's suggested that approximately half people with mental illness are help seeking and getting treatment. So this, I'll just go talk about depression a bit more. Like I said, the diagnostic criteria and things that we'd be looking for. So major depressive disorder, clinical depression, is a common and serious medical condition which negatively affects the way you think, feel and act. Can cause a person to lose interest in activities, that they once enjoyed. So that would be the thing. People might say to you, you know, I really used to enjoy walking, I enjoyed going out with my partner, I enjoyed going to work, I enjoyed studying, but now I'm just getting no enjoyment from anything. Even watching TV, I sit with people and they'll say that to me commonly. They'll say, I just feel nothing, I just sit, but I just don't enjoy it anymore. Decrease a person's ability to function at work and in their work, at home, sorry. And then this, we'll talk about this throughout it, just the difference, going back to those first slides, in mental illness that's diagnosed. So there's a difference in feeling sad. And although grief is an awful thing to go through, it's not depression, it's a different kind of thing. Do you talk about the grief cycle at some point? I remember going through that in one of my units here, so yeah, it's a really good one that you'll go through at some point. So these are the signs and symptoms. So these have come from the DSM-5 that I was discussing. And just to keep in mind that as part of the criteria diagnostically, a person would need to have, I think, 2 symptoms that last for a minimum of 2 weeks. So if you see someone feeling sad and low for a few days, if it's a situational thing, is different to clinical depression. So things that we'd be looking for is feeling sad and having a depressed mood, but prolonged for that 2 weeks. Loss of interest or pleasure in activities, which we've discussed. Changes in appetite. So this can be weight loss or weight gain. People will come for eat and eat and eat and put a lot of weight on, which then's got a negative, it's a domino, isn't it? Because people put weight on and they'll say, I feel so bad now, I've put this weight on, I'm struggling with motivation, I can't lose it. So it's all a big spiral. And on the opposite end, obviously, if sometimes people are low, they'll kind of stop eating their food and lose a lot of weight. This is common, trouble sleeping or oversleeping as well, so keep that in mind. Increased fatigue, so that's tiredness. So with this, people will often say to me, I've slept, my sleep's been okay sometimes, but I'm still tired all day long. Everything is exhausting me, just small tasks, doing the laundry, making dinner, just exhausted from it. Feeling of worthlessness and guilt. This comes into anxiety as well, actually, the feeling of guilt, which is quite common. People say, I just feel like I've done something bad all day long, and they can't switch that feeling off. And then this is a very important one. Thoughts of suicide, and I probably put self-harm in there as well, actually. And then I've just highlighted this, because I don't know, have you spoke about duty of care yet? And no?
I did it with group 2 yesterday.
Oh, okay. So I'll just briefly say, I don't know if anyone knows what our duty of care is in healthcare, but it's just our legal obligation to our patients. So with that, and we've also got to keep in mind confidentiality. So, you know, we're bound by that law, but with suicide, if someone's actively telling you that they're feeling suicidal, you do have a duty of care to report that. And I just wanted to emphasize how important it is to report that to someone senior. So like a therapist or a nurse or even a doctor if you were talking to them for any reason. And at this stage, I suppose that is the duty of care fulfilled, isn't it? Yeah.
Only report it, you don't need to do anything more about it.
And then you can go home knowing that you've done what you can, and it's for the nurse or the therapist to follow up. Oh, and I just put this in as well. You might go through this in your science units, but I just wanted to say some physical conditions can also present with mental illness symptoms. So like thyroid problems, for example, can have symptoms very similar to depression. And then on the other end of the spectrum, UTIs, urinary tract infections in older people to keep in mind for when you're in them residential aged cares, can present sometimes like psychosis with people, altered cognition, confusion, very different mental states. And these things can quite easily be treated. So just to keep in mind what's going on holistically with your person, could there be an underlying issue? Risk factors for depression. So genetics, is there a family history? Biochemistry, I suppose don't really get too bogged down by that. You learn more about that if you carry on to uni with neurotransmitters and things. But just to let you know that an imbalance can cause depression. Personality. And I think sometimes if you read that, it can seem quite harsh to say personality causes a clinical disease. But just to keep in mind, low self-esteem, feeling overwhelmed, kind of goes back deep-rooted with some people. So personalities coming from past experiences. We don't know what's happened in the childhood, in the adolescence, if there's a history of abuse. And it's not always our job to get into that, but just to keep in mind what the history is and why they're acting that way now, why they are depressed. Yeah. Environmental factors, neglect, it's kind of childhood or any time, violence, poverty, low socio-economical status. Just with this as well, in Australia this is very important, isolation. So people who live regionally, remote communities, statistically are way more likely to suffer with depression. You know, they might not be having any contact, so to keep that in mind. Male, female, we discussed that in the statistics. Age, we've talked about people having higher rates of depression in older age, but also I think suicide in younger males, 18 to 35, is at its highest, so age in lots of different categories. When I was reading this as well, I just read something that said about age discrimination and how that's negatively impacting older people. So again, when you're out there and you're working, just promote anti-age discrimination. You know, being old doesn't make people different. There's still lots of things that we can be encouraging them to do, engaging in community, in groups, just to help with these things. Chronic disease. So I think statistically people with chronic disease are very much higher likely to have depression. So that's things like cardiovascular disease, cancers, respiratory disease, Parkinson's, and then substance misuse, so drug and alcohol use. I've just also put, again, just to consider family members, carers that you're working with, and however you were looking after somebody with depression or any mental illness, the impact that it'll have on them. So just to be wary of everybody you're speaking to. Mental health affects everybody. All right, so this, when I wrote this slide, I was thinking of interventions specific to therapists and things that you could potentially do if you were working in mental health or in any area. So this is such an important thing, as in our communication skills and building rapport with people, and not to underestimate it. You do a communication unit as well, don't you? Yeah. And I wanted to say, when I did that unit, in all the training I've done, even at university now, working in mental health and the training I've had, that was probably the best classes that I went to in learning communication skills. So make the most of it while you're here, because if you carry on, or even if you stay, it's going to be one of the best kind of resources for you. And I've just put some little notes as well, just saying, with the communication, not to underestimate the little things. So for example, just listening to people, actively listening, showing them that you care, empathising. And the great thing is, when you're a student especially, or if you're in aged care, as an allied health assistant, sometimes you might have the time to go down and sit with somebody and just let them offload and listen. And quite often that can make a huge, huge difference to somebody's day. So, yeah. Yeah, I just wanted to say about this. I'm sure you've talked about it a lot with Terry already, but with everything, always individualised plan, knowing your patient, patient-centred care. Yeah. Help to develop health promoting routines, daily structure. So this is something I do with my patients a lot. I'll say about, let's make our first aim, getting up in the morning, having a shower, going for a walk, setting a meal routine, going to therapy groups if you're feeling up to it. But this is something that you can be doing, even in aged care, you know, just educating people on the importance and the benefit of these routines and the groups. Manage stress, promote relaxation and mindfulness. I'm a big fan of this, and I don't know if anyone's seen any of the apps that you can download now, like Headspace, and you can get a lot of them for free. So I generally really do encourage that. And again, we're mindful of our scope of practice. I know I'm not a psychologist, I'm not a therapist, but we can promote people and direct them to where they can get these things for themselves. And it's good sometimes to be doing that, because it's empowering people to say what's out there. And I'll sometimes say, why don't you do a bit of self-research, see what you can come up with, and we'll debrief later. And that's a really good exercise, because it's making people feel empowered, like they've done it for themselves. Changing habits of non-productive thinking. So CBT is cognitive behaviour therapy. I'll talk about that a little bit later on the next slide. We'll talk about it here. So CBT is all about changing thinking patterns, as it says. So people will go through various situations and just try and see how they can challenge their own mindset as to how they can differentiate between thoughts, feelings and emotions. And I'm very pro CBT. I've seen it work very well with people. But as with anything I say to people, there is no one fix, there's no magic wand. This is going to work with everything, with your routine, with your engagement with your family, potentially medications, but practice. So we do daily CBT groups and our patients get handouts. So I will always say, have you been through your handouts? Let's go through it together. How can you practice this? What can you put in your routine to be practicing these skills? And again, that's things that you can do. You know, you're not therapists that are going to be delivering CBT, but you can certainly be talking to people and asking them what they've learned, how they can practice it, what they did to practice it. This is very important. Again, with depression, like I said, people will be withdrawing, isolating. So let's encourage some connection to community, to family, social networks, groups, sports teams if it's applicable. Remembering individualised though, not everyone wants to join a basketball team, think what's going to be relevant to them and what they potentially could do. Promote sleep hygiene. So that's basically just avoiding caffeine at a certain time, setting up a good routine for sleep. So trying to go to bed, you know, relaxing by a certain time, lights out. And eventually if people do practice this, it does help with the sleep pattern. Therapy groups, one-on-one or group therapies. So we've talked about this. This one is dialectical behaviour therapy. I think it's a new kind of under the CBT umbrella, but it's more about acceptance and managing the emotions. So they'll learn a lot more skills if they're struggling with certain emotions as to how they're going to deal with a crisis. And this one is acceptance commitment therapy. Family therapy, very good. Social groups, we talked about that. Building resilience, this is very important. This hopefully will come from the skills that people gain in the groups. And then this, exercise, healthy diet, nutrition, get it in your routine. Can we go for that daily walk? Build it up to something more. Very good, like so much research in the benefits of exercise in mental health. I've just put this in there. Obviously therapy is very important, but just so you're aware of the bigger picture as to treatment plans for depression. So medication, it does have its place when needed. For example, if someone comes in and they're very depressed, medication, like we've got a patient at the moment and we were discussing this with a doctor in the multidisciplinary meeting, and she started a new antidepressant and she's spending most of the day in bed, and we as nurses and therapists have been trying to engage to get it to groups, but the doctor kind of educated us, I suppose, and said where she is now is just so depressed, we need to get the medication to a therapeutic level and then we can encourage these things. So, there is a time if needed, just to be mindful. This is more of a nurse thing, but with medications, to be monitoring for side effects. ECT is electroconvulsive therapy. We do that in my hospital. That would generally be given for a major depression. So if someone is catatonic, assessing risk if someone is highly suicidal, if they're very low. Also, there would be a hierarchy. If they're resistant to medications, resistant to other things, let's try the ECT. That does come with its risks. So, for example,
Describe what that looks like.
what the ECT looks like.
I don't know if these guys
Sorry.
have seen it.
So,
Don't they have a newer therapy, like just ECT and magnets?
yeah, I was going to talk about that as well. I'll finish on the ECT, it's transcranial magnetic stimulation. So we do that as well at my work. I'll talk about that in 1 minute, that's a good question. So ECT is given with general anaesthetic. So we do a course of 12 treatments and we do it 3 times a week, Monday, Wednesday, Friday. So people will go in, have the general anaesthetic, like with any surgery, fasting. They're given propofol for the anaesthetic, and they're also given succinylmethylporium, which is a muscle relaxant. So I don't know if anyone knows much about ECT or you've seen any videos on YouTube or old movies, but it's very dignified, very kind of fast now. There's no big jerky movements. They're given the muscle relaxant, given the treatment by a psychiatrist. There's an anaesthetist in there and a nurse as well. It's all in and out. So I do, not the treatment, but I work in recovery as a nurse. So they'll do it in treatment, from anaesthetic, from treatment into recovery, I'd say within 10 minutes, in and out, all done, and then we'll recover and manage the airways. Just the thing to be conscious of with that is the risk of cognitive decline. So sometimes people will experience cognitive issues, initially short-term memory loss after the treatment, but then there is the risk of long-term memory loss as well. But we as clinicians, therapists will probably do this as well, will be constantly monitoring cognitive state. So as part of our team, we will discuss with therapists every morning. We have a meeting and we'll say, Mrs. Smith has had 8 ECTs now. How have you found them in groups? And the therapist will say, I've noticed compared to previously, they're a little bit slower in the answers. There seems to be a change. So that's something that, again, you can be monitoring for. Does anyone want to ask anything about ECT? So TMS is a newer treatment. I'm not sure how long it's been around, but it is relatively new, maybe 5-6 years. So it's transcranial magnetic stimulation. I do that treatment at work. We kind of did specialised training in that, which was good. So that is 2 magnetic coils. There's all different machines on the market, and the doctor will kind of do treatment parameters, find out the treatment spot for a patient. Generally a nurse, we work out where we apply it, which is just above the forehead. Treatment lasts for about 45 minutes. So the 2 magnetic coils will stimulate with an electronic current, and the idea is that they stimulate the brain to increase neurostimulation. So the neurotransmitters will kind of be stimulated in the hope that that helps. And we do see good results with that as well. Our patients have a course of 20 treatments and there isn't any real side effects that have been observed in the research. So there's no cognitive impairment. The only thing that in my training they taught me and that I've personally noted with patients is mild headaches afterwards. But that alleviates with Panadol.
So that's still classified as a specialist treatment?
Mm-hmm. Yeah.
So you only find it really in private facilities and everything else?
No, public do it. Charlie Gardner's do it. Charlie Gardner's, I don't know if Royal Perth do it, but Charlie's definitely do it because one of our patients has had a history of seizures, and that's something that you need to be mindful of. So he goes to Charlie's for his treatment because they've got more general facilities. So if they needed backup from a medical team, then they've got that available. But no, yeah, it's given in the public sector as well. Any questions on TMS?
How long is like this?
Sorry.
Like 20 minutes before this transmit magnetic stimulation goes, or it's just when the session is given?
Oh, so the session is about 40, 45 minutes.
So as a therapy assistant, they are with 20 to 40 minutes, they are with.
No, you wouldn't sit in the treatment. It's generally,
It's electronically.
no, there's no risk like with the electrical current or anything, but it's a nurse that needs to sit in there just to monitor, because we need to be aware if there was a seizure, we're there with a trolley if we need to manage airways or anything like that. So that's more of a nursing role. But yeah.
Are they awake or they're not under general
Oh, sorry. Yeah, they're awake. Good question. Sometimes you forget when you do things all the time, you forget what people don't know. But yeah, there's no general anaesthetic. No, very uninvasive. Let me know if anyone thinks of anything and you want me to go back to that, because yeah, I'm conscious sometimes when you do things yourself, you forget of the basic kind of things to tell people.
Sorry.
Yeah.
With the ECT, because I think it could be generally very skin, and how would you prepare a patient? Like their mental well-being of it, because
Yeah.
you could say it's been
Yeah.
invasive and that's.
Yeah, that's a really good question, and we at work have been trying to engage all staff in educating them as to what happens for that very reason. So the therapists and the OT students now come and watch ECT. So did you go and watch as well? And it's just so you can alleviate the anxiety if you've seen it yourself from people.
Yeah, I found that people were really looking forward to it. If they'd had it before, they felt the benefits of it was so good. They would be looking forward to it, getting really excited that they were having their next treatment coming up soon.
Yeah, and if people have been so low, but what?
Yeah, it would never be forced on somebody.
Oh, no.
It's always,
Yeah.
it's an optional treatment.
Because there is still a bit of stigma around the electrical.
Yeah,
That's actually a good thing to actually show you and everything, and
yeah.
just the patients, they can have anxiety disorder, be like, oh my god.
No.
And it can just spread around to the
Yeah,
facility.
yeah. That's
Facility.
definitely right. What I personally do is I had a patient last night that was going to be having it for the first time, and we went through this because she was quite anxious. So I explained the procedures, kind of the time frames, and I will orientate them to the suite and the recovery area as well. So I'll take them down, show them the environment that they're going to be in, explain what's going to happen. And in my experience, that generally alleviates people's anxiety a little bit if they know where they're going and what it's going to look like on the day and things. Does that answer the question?
Yes.
And just, is it more because of chronic depression that's been going on for a long time before they sort of do things like this?
Oh, it'd be very different. So possibly, but sometimes it could be in an acute phase, especially in a public hospital if somebody's gone down quite fast, because people can be put under the Mental Health Act and involuntarily be given it. But then that's more of a doctor's question, to be honest. I'm not 100% on the criteria, because they would need to demonstrate that they've tried alternatives first. So they'd need to say in the documentation that they've tried certain medication, the patient's not responded to it, potentially tried TMS and they've not responded to that. So it should be a last line. So yeah, I suppose chronic people that have tried other things would do it and hopefully work well for them. But it's the risk, it's weighing up the risk as well, which we'll talk about in a little while. But if that person is acute, if it's an acute presentation, but they're a high risk of suicide to themselves or risking somebody else, then that's when the call would be made as to whether they should go straight to ECT. So that's kind of depression in a nutshell, and I'll talk a bit about anxiety now. So anxiety can be a normal part of life, as we know, as a reaction to stress. This can sometimes be beneficial as it helps alert us to danger and enables us to act. So did you say you've already been through the nervous system and fight or flight?
Yesterday,
Yeah.
in the body's lecture, we talked about fight and flight response and the sympathetic and parasympathetic
Yeah.
nervous system.
Which has probably gone over everybody's head now, hasn't it? You'll hear about this a lot. So especially if you carry on like the nervous system and fight or flight, this is going to come in a lot. So I would keep your notes from that class and just try and get that into your head. So I've wrote down, just to reiterate, the fight or flight, the different branches of the nervous system. It's the peripheral nervous system, and then underneath that you've got the autonomic nervous system, which has two branches. You're doing well. The sympathetic and the parasympathetic. So the sympathetic, I always remember it as in it acts in sympathy. So that's where your body fights or flight, and that's where this anxiety is going. Or the alternative is your parasympathetic. I hope that makes sense. Which is rest and digest. So the point of that is just to remember anxiety is a normal part of our life. Coming in here today, I was a bit anxious. You were probably anxious starting studying again. You know, we get anxious about a lot of things. But thinking back to the depression, what's the difference between normal anxiety or debilitating anxiety? Is it affecting our lives, our work, our relationships? That's just kind of what I've put in here, the difference. So it's the most common of mental health disorders, and it affects about 30% of adults at some point throughout our lives, so about a third. Anxiety disorders can cause people to avoid situations that increases or worsens the symptoms. So this is very interesting because you will find this all of the time. You've probably done it yourselves, you probably know people that do it. I don't want to go to class, I'm anxious, I don't want to do this, I'm anxious, so you stay home, and what happens? The anxiety increases, the spiral continues. So this is what I talk about with my patients a lot, about kind of coming up with strategies to face a situation. And then this is from the DSM-5 again, so that Diagnostics and Statistics Manual. This is the criteria of some of it. So the anxiety must be out of proportion to the situation or age inappropriate. And then I've just put a little example in my notes is I can think of younger people that will be extremely anxious, like adolescents, talking about finances and bills, and really that's age inappropriate because it's not always going to affect their life. Like maybe for some adolescents, but that's the difference. Do you know if you had a 40-year-old person that was saying, I'm anxious about paying the mortgage, it's kind of appropriate sometimes for all of us, isn't it? But is it appropriate to the situation, the person's age?
So it's like that repetition of like constantly stressing about that one thing and then constantly repeating about it. So if you have a partner or something, you're constantly worrying about the same thing.
Yeah.
It's not just affecting
Yeah.
It can be something that affects everything in life.
And people will say that, you know, they'll say, I feel like my partner's going to leave me, and I feel like this, and I feel like that, and it's ongoing, and then it can have negative impacts on the relationship. So I will say to people, what makes you think this? What's the evidence that's making you think it? And that's a little bit of a CBT model where you're challenging thought patterns. But yeah.
It's that someone's repetition, if you constantly think about something. It's
Always.
Like you constantly press a button.
Yeah.
Aware of that, you know, constantly.
Yeah. And that's right, that's the difference between being anxious about coming into here or going into a new situation or all day long.
You're feeling that.
Yeah. And that's the thing that you learn in your science classes about the symptoms of anxiety and how they affect your body systems. So anxiety that's a really good point actually, anxiety will present so differently. So people will say to me what you're saying about the thoughts and they're going on, but other people will have physical sensations. So they'll say, you know, I've just got this feeling in my chest, this crippling feeling that doesn't go away, or I've got tension, headaches, or I've got a bad stomach.
See it in their face as well, like
Yeah.
fatigue in their eyes and everything else.
Yeah.
Sometimes.
They're just pained by something. That's a good point. And then we've talked about this as well, that it's hindering the ability to function. So you'd find, and this is where anxiety and depression are linked, because somebody could have anxiety and isolate, they don't want to face the situation, but what's going to happen if you're isolating and you're not seeing people and you're staying in the house? You're going to get depressed, aren't you? It's all going to link together. Just some risk factors for anxiety. So when I was reading up on this, it said that the exact causes for anxiety aren't currently known entirely. So there's a lot of different contributing factors. And this is the thing for me in all mental health. It's not going to be like general where you can say, oh, somebody's had a car accident or they've had a stroke because of diet. You know, there's always going to be a lot of different things contributing. So just to be mindful of that, it's very much more holistic. But there's a contribution of things, so genetics, again, family history, psychological, situational, what's happening in their life at the moment, developmental, what happened when they were growing up, did they get learned behaviours of anxiety from parents, was the trauma like we talked about before, a combination of genes and environmental stresses can develop to the disorder. So again, these are just some treatment interventions for anxiety. And these are things that you can be doing as well with people. So yeah, you might not be providing psychotherapy, absolutely not, but you can educate people on the benefits of psychotherapy and the importance of getting into that group. And in my hospital, for example, this is one of the common things people say to me: I don't need to go to group, I don't find it beneficial, I think CBT is rubbish. So I then go back to the routine and I say, well, you know, that's entirely your decision. It's obviously working very differently for people, but it's your choice what you want to do. Do you think it's going to be better to stay in bed, or could we look at setting a routine, as part of that routine, get to group? Even if you just get 5% out of it, you're still going to learn something new today. You're going to be out of the room, you're going to be around people. And I generally leave it with people to try and come up with the decision themselves, but just educate them on what the benefits are and the way that you approach it. Stress management techniques. So these are things that they could be learning in the group. Is there any kind of specific techniques that you'd go through with people?
Like breathing,
Yeah.
got relaxation there,
Meditation.
so, yeah.
Building resilience, like I said before, that's very important.
They could easily be doing relaxation groups.
Taking a minute and thinking about what you're saying or doing as well, instead of just running out of a situation or just getting anxious about the situation. Just like think about something else. Let your mind wander off from this
Yeah,
scenario.
definitely. Pet therapy is a good one. Has anyone got pets and the benefits kind of that it does for your own anxiety and stress? We do this at work once a week actually, and it is one of the most popular groups in the whole hospital. Everybody loves it. Art therapy is a great one. I've put medications in there because, like I said, I just wanted to acknowledge that there is a time and a place for medications. Exposure therapy. So I mean, psychologists and maybe OTs would have more formal ways of doing this. But when we were saying about the avoidance with anxiety, I will say exactly that. I'm quite direct with the way I talk to patients. So I'll say again, you've got the choice now. Is it gonna stay better if you stay in that room? Or could we come up with small ways to face it? So say if people are socially anxious, I'll come up with very small goals. So I'll say, look, initially, why don't we, and I'm thinking in terms of hospital admission, so I'd say, why don't we set the goal where you'll just go to the dining room for your meals for the first few days rather than staying in your room. So that's small, realistic exposure goals, you know, sitting in a social environment. You don't need to smoke to people. And then we'll build it from there. And I'd say, well, why don't we today maybe aim to go down to Coles, see how you go in public around people. So just small exposures. And there again, things that you can be encouraging people on. Like, that's realistic scope, isn't it?
Yeah, a couple of our ex-students are working in older adult mental health at
Yeah.
Fremantle, and that's the sort of work they're doing.
So they would
Going
escort
out,
them, would
they're
they?
out in the community,
Yeah.
seeing people and taking them out, maybe going to the local shops, catching a bus or a train, that kind of thing. It's something that's ideal work for an allied health assistant.
Yeah.
If you're into that sort of thing, it's a great opportunity, that kind of work.
They're great jobs. And just with this as well, lots of positive reinforcement I find with people. So I would say, you know, I know that you struggled with that. I know it's not easy for you, but you did it and you should be proud of yourself. And I like positive reinforcement.
Reinforcement's important for us not to baby them, per se.
Yeah.
Down, that's a lot of
No, I know exactly what you're saying, but then you, I suppose,
you got to find that
Yeah.
points.
that's right. And I wouldn't always say that to people, so that's a good point. I would kind of judge the person and see whether or not it's appropriate.
Because they can build up an anxiety from that as well, be like, why are they treating me like this?
Yeah,
And you can see around the support groups, so we're going to be very careful, especially in group therapy.
yeah, no, for sure. Support groups, avoid caffeine. And yeah, like Terry was saying about stress management, deep breathing, that's something I talk about a lot, breathing exercises. So this is just another one, I'll just briefly go through this. We do get some presentations at my hospital with this. So if you've got any questions, feel free to shout out. So this is kind of an umbrella term. There's a few different disorders within it, and it's defined again by the DSM-5. A group of brain disorders that causes extreme function in a person's mood, energy, and ability to function. Kind of sounds similar to depression, doesn't it, when you first read that, but it is different, and I suppose the differences are with this, people will have periods of being very elevated. So I'll let you read through this, but this one is what we'd be looking out for. Let me just see what I wrote down. People who live with bipolar disorder experience periods of great excitement, overactivity, delusions, euphoria, and then have periods of sadness and hopelessness. So I don't know if anyone's ever experienced or seen people with this, but we sometimes do get patients that will come in and be very, very elevated, very excitable, very difficult to contain sometimes, quite disinhibited even, which would be a reason for the admission. Quite grandiose, that means kind of people will have a belief that they're very, very important. So I remember sitting with somebody, with the doctor and a social worker, and he was saying, I need to get out of this hospital, I've got a business and millions of dollars, and the business is going to go bust, and I've got all this going on, and like the Prime Minister's been contacting me and I need to get to meet him. But then the reality was the social worker was organising Centrelink because he didn't have any money. Do you know, and it's quite interesting to be around these people, isn't it? So if you hear the word grandiose, that's what it's referring to. People will have these delusions of grandiosity where they'll be very, very thinking they're important. Reasons for admission for this is people will kind of be a risk of spending lots of money. So sometimes if people are elevated, like I said, they're disinhibited. So there's been times when people have literally gone on their credit cards and spent thousands and thousands and thousands of dollars. So they've got a risk of financial ruin, risk of reputation. People can be quite promiscuous as well. So just keeping in mind, people have different personalities. Some people may be naturally promiscuous, but the difference is if it's a mental illness and people are acting differently, that's where maybe they need an intervention. More talkative, so yeah, that's the thing. People will be very rapid and talkative, like they'll come up to the nursery station, Lee, did you know that? It can be entertaining, but then it's difficult to bring them down, and it's difficult to manage a ward with other patients because they'll want all of your time. But unknowing, like, it's the illness, which you've got to remember. And generally decreased sleep. So sometimes these people won't sleep at all or have very, very minimal sleep. And then I've just put a few interventions. I'm not going to go into this as much as the other two, but a big intervention for this is to reduce stimuli. So you don't want them in groups around lots of people, lots of music, lots of sounds, lots of colours. You want them in a quiet environment just to try and kind of bring that down. Encourage sleep. Generally, these people are going to need medications, so they're going to need to see the psychiatrist and medications to help the sleep, bring the mood down, monitor the safety with all the things that we discussed. Any questions on that? Psychosis. So this is characterised or defined as a disconnection from reality. So I remember when I went on my very first placement to Royal Perth on mental health, and I was kind of unsure what this was, quite afraid as well really, not sure how people would be around me. But there's different levels of psychosis. People have lost contact with reality, but that doesn't always mean that they're going to be dangerous or they're going to be a risk to you. So what I'd say is if you work in mental health, just to be mindful, but not to be afraid. And I'm sure they'll teach you, if anyone goes out to a ward, the staff would supervise you and
so these guys will
educate you more.
into an environment on their placements, but if you do Cert 4 and residents with mental health, you could be going out onto mental health wards and see people with psychosis.
So this has come from the DSM-5 again. So characterised by two of these. So delusions, which is a fixed false belief. So someone would say, like the man that was grandiose, his mind, he owned that business, he was a millionaire. So that was his delusion. It was an absolute fact in his head. That was the way that it was. Or hallucinations, and then a hallucination is kind of, people will feel that they see external stimuli. So that can be any of the senses. So people will say, I'm seeing people, I'm hearing voices, but also smelling things, olfactory hallucination, tasting things in their mouth, feeling things. I remember having a patient that was once delusional and kind of hallucinating that she smelled a BO and she would obsessively wash. So she'd always be in the shower and then she wouldn't go to group because she would be so delusional that she smelled a BO and it was offensive to everybody else. It's very sad. She got better with ECT actually. That was a lady that had ECT and she got very, very good results from it.
Would you differentiate, because I know there's cat psychosis and other sorts of drugs, how would you differentiate, or would you have to in mental health wards?
What, in diagnosis or treatment?
In treatment.
For me, like I said, we don't really get, to be honest with you, too many presentations like that. That'd be more on your lock wards. But I personally, generally, and I've spoke to a psychologist about this, try to not get too bogged down with diagnoses and just the individual, going back to the individual care, you know. So you can read in textbooks, with this we should do X, Y, Z interventions, but be very mindful just to read that individual person the way that they're presenting. Do you want to add anything else on that?
No, I couldn't put it betterly. Yeah, it's the individual you're dealing with, not the condition.
We had a psychologist that once said that. A nurse went in a review and the nurse said, what's this man's diagnosis? And the psychologist went mad at her and said, I don't deal with diagnoses, I deal with people. So I think she was very holistic. She got to know the person before she came up with a plan, which is great really now.
So it's just
yeah.
utilising them.
Yes. And that's the thing, like, I'm passionate about reducing stigma and...
They're a person first, and the diagnosis is just something that is
Yeah.
temporarily attached to them.
That's right.
But they're essentially, they're the person, and that's what you're working with, not a diagnosis.
So yeah, disorganised speech, grossly disorganised, catatonic behaviour. Catatonic behaviour can also be for major depression as well. People can be kind of unresponsive, not getting out of bed, not eating. So that's what, if you hear that term, that's what that means. Negative symptoms. Oh, so the negative symptoms, I just wanted, you may hear with schizophrenia specifically, positive and negative symptoms, which sounds strange to get positive symptoms, but it basically just means things that are taken away or things that are added. So a positive symptoms might be like the hallucinations and things that people have got that they didn't have before, but negatives are like not doing the ADLs, withdrawing from relationships, not going to work, so they're all the negative symptoms. And then on this I've put in here but could be relevant to any condition, but I just wanted to mention about involuntary admissions. So I know you were saying about public hospitals, so like Charlie Gardner's, Fiona Stanley, Joondalup, all have kind of locked beds, so somebody would potentially be put under the Mental Health Act and detained involuntary. Detained's the wrong word really, isn't it? But kind of held in the hospital. Yeah. So yeah, there's lots of different, I don't really want to get into that because you could read all day. I had to do a 5-hour training session on it about all the different forms and the criteria that people need to be met. But just to make you aware that there are involuntary admissions.
They don't need to worry.
No. And then just some kind of reasons for admission. So this is in general, like not just an involuntary. So manage risk, self-harm, suicide, reputation, like we were talking about before with promiscuity, financial, risk to others. So someone may be really, really delusional and get a belief that somebody's out to get them and go to get them back. So they need to be held to protect the public as well. acute phase of illness. So I've just put that in there because we will sometimes get people that come in for us to assess and the doctors assess just to help paint more of a picture for them to build up a treatment plan. Because imagine if someone stayed with the GP and you're seeing a GP once a fortnight or however often, how can they possibly assess you and get to know the full picture? Whereas this is why we use our multidisciplinary meetings and we're all liaising, because it helps for everybody to get to know them, doesn't it? For us to decide how we're going to manage the plan. Better access to these things as well. So sometimes people will come into my work specifically for the daily therapy plans and they get huge benefits from it. Access to social workers, welfare officers, psychologists, allied health assistants, pharmacists, like all the MDT really. All right, I've just put this in here. This is a tool that we use in mental health to assess our patients. So don't get too bogged down with it. I just wanted to kind of give you an example of something that we use every day in every mental health hospital. And therapists would use this as well with the NMSE in mental health. So it measures a patient's cognitive, appearance, risk assessment. And it's basically when you do your MSE, it's just a snapshot of that moment in time. So as you can see, there's 10 different domains. I don't want you to worry too much about them. Maybe if anyone plans on working in mental health in the future, you could read up on this a little bit more. But the point that I was, like if I did an admission, I would go into this in depth with each person and give examples as to how they feel in that way. But for you guys, I just kind of wanted to show you, if you hear the terminology being used, it's basically just showing how that person's presenting. And if you, even in aged care, this would still be relevant in a way, because if you were doing a group and the therapist said, so how was Mr. Brown in the group? You then can think of these type of tools and say, well, you know, he was appearing quite well, he looked like he'd had a shower this morning, he'd brushed his hair, his behaviour was settled, he was engaging with other people appropriately. Affect's just kind of how your facial expression is. So you'd say his affect was reactive. Mood seemed okay. I asked him, he said his mood's 5 out of 10. Speech was congruent, fluent. That's just a little example, but just to kind of keep that in mind, if you want to read it more, I just wanted to kind of show it to you. Cognition as well. Again, with these things, it's not always going to be, we do have different assessments, and in OT you'll have heaps of assessment you use for cognitives, won't you?
What's very easily confused with this is the mini mental state
Yeah.
evaluation, the MMSE. So you've got the MMSE.
Oh yeah, that
which
you
is
use
about
more.
More the mental health
Yeah.
assessment. Mini mental state assessment.
Is
examination
specific
is about
cognition.
And thinking and perception and asking questions like, do you know where you are? What day is it? What year is
Yeah.
it? Can you subtract 7 from 100?
But even in that, like, if you were with somebody and the therapist said, did they seem orientated, you could just come back and say, look, I asked them, they did know that they were in hospital today, do you know? So you can just be saying little things like that. It doesn't always need to be a formal assessment tool, but just to be thinking those things so you can liaise back to the team.
Yeah, and then the therapist can do a full assessment.
Yeah, if needed, you can say, look, I'm worried about the cognition today. I asked them what day it is. They said it was Saturday. Do you know, just little things like that. And that's it. Any questions?